So, as she mentioned, my name is Kelly Kronsberg, and today we'll be talking about penicillin allergy labels with a focus on the mechanisms of allergic reactions, essential details when you're taking a patient allergy history, and the implications of reported reactions. Similarly, our learning objectives for formality is to review the types and mechanisms of allergic reactions, go over how to differentiate an allergy from an adverse drug reaction, and discuss the best practices when performing a patient allergy interview, and round out by identifying potential barriers to allergy delabeling. Now, first things first, whenever I want to talk about a topic, I want to establish why it's worthy of our time and attention today. A commonly cited number is that 10% of the population reports having a penicillin allergy, although this can vary from 5 to 15%, depending on what source you look at. And of that, approximately 1 to 2% of patients are truly and currently allergic to penicillins. So 10 out of 100 will say they're allergic to penicillin, but only one truly is, and 9 patients are essentially mislabeled. And the reason why we're talking about penicillin allergies specifically is because out of all antibiotic allergies that are reported by patients, penicillin allergies typically comprise about half of those. So this is going to be the most common antibiotic allergy that's reported. Now, if we're asking ourselves, why are 9 out of 10 patients mislabeled? There's a few potential reasons for this. The first would be that the patient had an actual reaction to the antibiotic that wasn't a true allergy. Because, as we'll be talking about later today, allergies are mediated by the immune system, but not all reactions are an allergy, right? There can be medication side effects or adverse effects that could be conflated in the patient discussions. Another possibility is that the patient has a family history of having an allergy to that antibiotic, and that has created a sense of fear around taking that medication, or a concern that perhaps allergies are hereditary or genetic in nature when they aren't. Or perhaps there was even a close friend and the patient has anxiety around taking that medication, and so they state that they would prefer not to. The last reason is that the patient may have actually had an allergy earlier in life because a lot of reactions are reported in childhood. However, for certain types of allergies that are mediated by immune globulin E, these actually wane with time. And after about 10 years from that initial reaction, 80% of patients are no longer allergic, which would make it not a current allergy, even if it was true in the past. And then, why is this worth our time to talk about? We've established patients are mislabeled, but what's the big deal? And there's quite a few implications for patients who are labeled as penicillin allergic. First and foremost, approximately 30% of those patients, the provider will choose a different second line alternative antibiotic in order to avoid the penicillin or beta lactam family, of which penicillins are a subclassification. And this is often a broader spectrum antibiotic, such as vancomycin, fluoroquinolones, or clindamycin. And along with this broader spectrum, which we don't love from a stewardship standpoint, these antibiotics have higher rates of adverse events, which may include kidney injury, heart abnormalities, tendon injury, and along with these more toxic concerns, they also have been shown to be less efficacious in certain scenarios. So, for example, when giving an antibiotic for preoperative prophylaxis, using an alternative has resulted in higher rates of surgical site infections. Or for treating specific bacteria, using an alternative has resulted in worse infectious outcomes. And along with these broader spectrum agents, we're seeing higher rates of multi-drug resistant organisms in these patients. And that can include methicillin-resistant Staphylococcus aureus, or MRSA, vancomycin-resistant Enterococcus, or VRE, or Clostridioides difficile infections. Along with all of this, we also see that these patients tend to have increased lengths of stay, which makes sense if we're seeing increased rates of multi-drug resistant organisms and adverse effects or efficacy concerns. And then all of these combined lead to increased costs for both the patient and the healthcare system. So there's quite a few negative outcomes that are associated with patients who are labeled as penicillin allergic. And we need to be mindful that 9 out of 10 of these don't have a true or current allergy, and we should be really taking what steps we can in order to remove that allergy label. And it's as easy as talking to the patient a lot of the time, which is kind of an interesting way to think about it because we talk to the patients in order to put that allergy in the record. But upon revisiting that allergy documentation, studies have shown that 22 to 76% of those entries need to be modified or clarified after discussing further with the patient. So this is an easy step that's really worthy of our time and attention. And in 2023, 64% of Arizona acute care hospitals report having a formal policy or procedure to assess and clarify documented penicillin allergies, which is above the national average. That was 53% for 2023. But I'd really love to see us closer to 100% because this is so accessible and can be so meaningful to patient outcomes. And there's 3 different ways that we can assess patient allergies. Today, we're really focusing in on the interview, both for the time and the scope of this presentation, but other methods include a direct oral challenge, and for penicillin allergies, that would be using amoxicillin typically, or undergoing skin testing. But these often require a little bit more education and training, so I'm keeping it focused on patient interviews today. The other foundational piece when we're thinking about allergy labels is, well, what's an allergy? So let's talk a little bit more about that. As I mentioned, the key component is that allergic reactions will all be caused by the immune system interacting with the drug. And there's 4 different types of allergic reactions or hypersensitivity reactions. And type 1 is what we're going to think about when we think of a stereotypical allergic reaction. So this is going to occur very quickly. It's caused by immune globulin E or IgE, and it interacts with mast cells and histamines, and it causes a raised itchy rash or hives. It can lead to throat swelling, chest tightness, difficulty breathing, all the way up to anaphylaxis, and it occurs very quickly and is very severe and often life-threatening in the setting of anaphylaxis or anaphylactic shock. So type 1 is going to be our stereotypical, and this is where we have the most data as well for how to manage patients who have a history of an allergic reaction. Type 2 is going to be a little bit more delayed. It's caused by immune globulins IgG or IgM, and these immune globulins are attached to certain cells throughout the body. So when the drug interacts with it, it causes that cell to be damaged or die. And these can be on red blood cells, which we would call anemia when they're going away. And hemolytic anemia is when they essentially burst open those red blood cells. It can be attached to platelets and result in low platelet counts, or even the kidney cells and result in kidney injury. For type 3 allergic reactions, this one also takes a little bit longer to occur compared to type 1. And in this scenario, those immune globulins aren't attached to a cell, but they still form a complex with the allergen, in our case, the drug or beta-lactam, and they float throughout the bloodstream and deposit in certain areas, and that's where they cause the reaction. So it can deposit in the blood vessels and cause a vasculitis or serum sickness. It can deposit in the joints and cause a joint pain or arthritis, or arthralgia would be another term for that. Or it can deposit in the kidneys and cause a kidney injury, again, a slightly different mechanism compared to type 2. Lastly, we have type 4 allergic reactions, and these are the most delayed out of the 4 different types. These are mediated by T cells, and it can have some mild to, once again, very severe presentations. So the hallmark worst case scenario we think about with type 4 would be skin blistering or coming off. There can be sores in the mucous membrane, such as the mouth, and certain diagnoses for this would be Stevens-Johnson syndrome or SJS, toxic epidermal necrolysis or TENS, or drug reaction with eosinophilia and systemic symptoms or DRESS, but it can also be a mild rash. And to try to make this a little bit more accessible to what I think a lot of us have experienced in the healthcare and public health arena, is that if you've undergone a PPD test where they inject tuberculin intradermally and you come back in a few days to see if there was a raised area, that raised area would be due to a type 4 reaction occurring where it's forming complexes and reacting at that specific site. So just to try to make a connection outside of this hypothetical hypersensitivity discussion. But the commonality here is going to be that they're all caused by the immune system. And I want to be mindful that we have the most data for type 1, and any sort of guidelines or primary literature will be really focused on how to handle patients with those type 1 stereotypical allergic reactions. And I want to emphasize that because when we ask patients if they've had a reaction to a medication before, they may think of an adverse reaction, which is not an allergy. That's a consequence of the drug rather than a consequence of the immune system. So, key words that we should be thinking about and asking patients about to elicit an allergy history would be a raised itchy rash or hives, swelling, trouble breathing, wheezing, chest tightness. Sores in the mouth would be indicative of type 4, although those patients usually know their specific diagnosis because it's so extreme, or new joint pain. Whereas adverse reactions might be things like nausea, vomiting, diarrhea, fatigue, bruising, headaches, or lightheadedness. And once again, these are not allergies and not reasons to avoid the medication because they aren't going to be life-threatening. And we have some ways that we can potentially manage these, which I'll be talking about in a little bit. So we're coming up to our first knowledge check. I've done quite a bit of talking and I realized that my natural rate of speech is a little bit fast. So I want to make sure that everyone's following. For the first question, is antibiotic-induced nausea an allergy or an adverse reaction? I'll give you guys a few seconds to answer that. I'm seeing some answers coming in, which is great. And it looks like everyone's on the right track. I'm going to pretend that I taught you guys this, but I know that you probably already knew this as well. So perfect. Nausea is an adverse reaction rather than an allergy. It's not caused by the immune system. Perfect. Let's try another one. Is antibiotic-induced trouble breathing an allergy or an adverse reaction? So we have allergy, adverse reaction, or if you think it's something else, you can put that in the chat as well. Giving a few seconds as some answers come in. Thank you all for your participation. It's really appreciated. It looks like we have a little bit more hesitancy with this question, which is okay. I appreciate you guys participating. So the majority of people did correctly identify that this is an allergy. The trouble breathing is something we associate with type 1 or IgE mediated allergic reactions, and that's something that we need to pay a little bit more attention to and find out additional details about before proceeding with a similar antibiotic. For the next question, is antibiotic-induced headache an allergy or an adverse reaction? Or if you think it's something else, you can type that in the chat as well, or simply select C. It looks like we're feeling a little bit more confident on this one too as answers come in. You have the clarification, is this alone or with other symptoms? And this would be alone, just a headache is their only complaint. Thanks, Kelly. Perfect. So the majority of people answered that it was an adverse reaction. And realistically, there could be a lot of other things going on in the patient's life, especially if they're sick and being prescribed medications acutely. And those stressors, dehydrations, a lot of things that can cause a headache, but ultimately not caused by the immune system in the vast majority of cases. Okay, last one. What about a rash? Allergy, adverse reaction, or is there some more considerations here that we need? Give some time for people to answer again. Thank you for your participation. Okay. So the majority of people answered allergy, with a couple people saying other, especially clarifying if there's a viral reaction. And rash is very nonspecific. And I wanted to highlight this because it's a very commonly reported reaction by patients. Oh, I had a rash. Well, a raised itchy rash is indicative of an allergic reaction, especially type 1, or blistering could be indicative of type 4. But in many scenarios, a rash isn't necessarily caused by the immune system. There's other things that could be going on. It could be a heat rash. There can be an interaction between certain antibiotics, such as amoxicillin, and certain viruses, such as Epstein-Barr virus or EBV, where if the patient's infection, especially an upper respiratory or ear infection, is caused by a virus and the patient is prescribed amoxicillin, they can have a rash, but that's actually an interaction between the drug and the virus rather than involving the immune system. So this is one where we need more information to determine if it's an allergy or not. So I tricked you guys a little bit, but I wanted to make sure to discuss this in more detail because it is such a common conversation to have. Okay, so we will move on to our next section about what should we be discussing with patients. That was my segue in. And there are a few key components that I want to really highlight. The first is, what was the specific medication that the patient had a reaction to? We need the details, not just penicillins in general, but was it penicillin specifically, or was it amoxicillin, something else? We want additional details also about the reaction. How quickly after you started taking the medication or antibiotic did it occur? Was it within that first hour, or did it take days to weeks that would put the patient in a different allergy category? Did that reaction require treatment? Did the patient just need to stop taking the medication and it went away on its own? Or did they have to be hospitalized for anaphylaxis? Those are going to be two very different scenarios in terms of severity, and an important point for us to clarify. We also want to find out if the patient has taken similar medication since the event. And through this interview, we may be able to identify potential barriers to allergy delabeling, particularly if the patient has hesitancy or distrust in the information that's being provided that they aren't currently allergic. So we'll get into these in a little bit more detail. The first part that I wanted to talk about was similar medications and cross-allergenicity, keeping in mind that penicillins are a subclass of the beta-lactam group. And what makes the beta-lactams a group, I know I have a drug structure up on the screen. I'm going to go through very gently. So it's the two rings, the square and the pentagon, that have the blue background. That's the beta-lactam core structure. And from penicillins to cephalosporins to carbapenems, that pentagon will be a different shape or have different components. But the square that's in red with the oxygen attached is the core beta-lactam ring, and all beta-lactams contain this. So this is the core structure, and back in the day, that's what we thought was causing an allergic reaction, was this core structure. And it was advised to avoid anything that had that in order to prevent future allergic reactions. However, we have more data today that that's not the case. And instead, it's the sequence of molecules attached to that, which is represented on this image by R and highlighted in yellow. And we call that the side chain. So now we look at the side chains for the different beta-lactams to determine if they're safe or not, or if we expect the patient to be allergic to option B if they were allergic to option A as well. And what I have on the screen is most of our oral beta-lactams and a couple IV ones. This was a chart that I created at my last hospital. And to orient you to it, if there's an X, that means there's cross-allergenicity. And so we'd probably want to err on the side of avoiding that. but if there's a check mark, then it's safe to administer and we don't expect cross-allergenicity. So for example, looking at penicillin, we would expect cross-allergenicity for amoxicillin, for piperacillin, which is only available in combination with tazobactam under the brand name Zosyn, with cephalexin, and with cefoxitin. And Zosyn and cefoxitin are the IV options that I kept on the slide in order to demonstrate the cross-allergenicity with penicillins. But other oral options, such as cefuroxime, ceftonir, cefixime, we would anticipate to be safe in a patient who reports an allergic reaction to penicillin, even if it is a true type 1 allergy. So I wanted to take a moment to emphasize that although these later generation cephalosporins do have cross-allergenicity within themselves. So if a patient has an allergy to ceftonir, we don't want to give cefixime. For the pharmacists on the call, you already recognize the different colors represent the different generations of cephalosporins and classes. I went all the way through the rainbow with carbapenems and aztreonam included as well. But this was a chart that I gave to our medication reconciliation team at the last hospital I was at, and they would go and use it in patient rooms when they were clarifying the patient's allergy history in order to have this reference readily accessible. And I think that a tool like this is very helpful for teams who are going in and discussing with patients who may not be pharmacists or physicians as familiar with the drug structure considerations. I also wanted to include a sample interview that I modified from one of the studies that performed in-depth beta-lactam allergy interviews. And so they discussed what specifically was the name of the antibiotic that you had a reaction to. What was that reaction when you took the antibiotic? They also asked specific red flag reaction questions and specified, did the patient experience throat closing, difficulty breathing, or facial swelling? And then did they experience Stevens-Johnson syndrome or SJS, toxic epidermal necrolysis or TENS, drug reaction with eosinophilia and systemic symptoms or DRESS, vasculitis, serum sickness, ones that would exclude them from that type 1 category essentially, or trying to elicit if it was a severe type 1 reaction. They also asked how soon after taking the antibiotic did that reaction occur. That can put the patient into the different classifications of allergy types. We also want to know how long ago that reaction occurred. Remember, for those type 1 IgE-mediated reactions, 80% of patients will no longer be allergic after 10 years. So if the reaction was greater than 10 years ago, that could point to a low-risk allergy history. We also want to ask if the patient has taken a similar medication. So since this was penicillin allergy specific, they asked about amoxicillin, amoxicillin clavulanate, piperacillin, tazobactam, and cephalexin. In discussing with patients, I find it helpful to also include brand names, which for each drug would be Amoxil, Augmentin or Amoxiclav, Zosyn, and Keflex, respectively. And then if they've taken it, we want to clarify, did you have a reaction to that medication or not? As I mentioned, amoxicillin is actually our drug of choice for a direct oral challenge. And if the patient tolerates that, we consider them delabeled. So that's going to be very important for us to know. And when I say delabeled, I mean no longer allergic to the penicillin. And then lastly, we want to find out if they've had any other assessments for their reported allergy. Have they had a penicillin skin test or an amoxicillin direct oral challenge? And if so, what was that result? And then we can use the findings from this interview to alter the documentation in the medical record or remove it completely. And there will be some caveats here for facility-specific practices. But if the patient denies a personal allergy to beta-lactams, maybe it was a sibling or a parent who was allergic, then we want to remove that allergy from the profile and educate them that there's no genetic or hereditary component there, and it would be safe to trial the medication based on the information we have for them specifically. If we interview them and determine that that reported allergy was actually an adverse reaction, we can either edit the entry type from allergy to adverse reaction in the chart if that's something that your medical record has the capability of doing, or just completely remove it from the patient's profile following education that this wasn't an allergy. So it's going to be a little bit dependent on what your facility wants to do. If you want to err on the side of over documentation or preventing the possibility of unnecessary alerts and preventing alert fatigue are going to be two of the considerations there. If the patient's tolerated similar antibiotics more recently, especially amoxicillin in the setting of a penicillin allergy, we want to document the date, time, and medication received in the profile, once again, if we're going with that high degree of documentation in the medical record, or just remove the allergy entry if the patient has tolerated it and we can consider them no longer allergic. If the patient undergoes an oral challenge without reacting, we also want to document in the chart. That will typically be a note since it's a procedure. That's the way I always approached it when I would perform those in the inpatient setting, and then remove the allergy from the profile because the patient has proven that they're no longer allergic to that medication. And I know that I said that I wasn't going to talk about the other allergy assessments, but I just want to pause for a moment there. And there was a systematic review and meta-analysis, I believe in 2022, and in patients who were deemed to be low risk for having a true and current penicillin allergy who still underwent an oral challenge, their history wasn't an adverse drug reaction. Only 4% of patients out of a few thousand had a reaction to the amoxicillin, and they were all managed by over-the-counter options such as diphenhydramine or Benadryl or loperamide or Imodium. So in identifying these patients who underwent an oral challenge, it was still quite low risk to proceed with giving a beta-lactam, considering no patients had an life-threatening reaction. So I just want to push a little bit towards the oral challenge, even though that's not our focus today, that procedure might sound scary and allergies can sound scary, but realistically, we have risk stratification tools that have made it a pretty safe thing to carry out. And coming back to the focus on the interviews, though, studies have shown that 13 up to 80% of reported penicillin allergies can be removed just by talking to the patient. And this is something that really any member of the healthcare team can do to talk to the patient to differentiate core things like allergy versus adverse reaction, or adding those additional details into the medical record. And I would be remiss if I didn't discuss what sort of outcomes we see after removing a penicillin allergy. There's two studies that have looked at this specifically that I wanted to include, and they had similar findings. The first is there's lower rates of broad spectrum antibiotic use, lower rates of fluoroquinolone specifically, as well as vancomycin and clindamycin. None of the patients in these studies who went on to receive a penicillin or a beta-lactam experienced an allergic reaction, which aligns with some of the thoughts of the low-risk penicillin allergy and even giving a direct oral challenge. And they also saw cost savings, which makes sense when we think back to the potential negative outcomes that the lower costs would be associated with using the beta-lactams. Now, since these studies were just during that hospitalization, it might have been too soon to see an impact on rates of multi-drug resistant organisms, but I would hypothesize that that is seen down the line as well, since we definitely do see that outcome with other stewardship measures. And I also wanted to make sure to cover society or guideline recommendations. So we have Quad AI, which is going to be our national organization on management of allergies, and they have a drug allergy practice parameter that came out in 2022. And they encourage that proactive efforts should be made to delabel patients with reported penicillin allergies. Those who report a reaction history inconsistent with an allergy should not undergo allergy testing. So these would be our patients where their history is more so an adverse drug reaction. We can just say that wasn't an allergy. We don't need to take any further steps unless it's needed to reassure the patient. For patients who have a remote history of a non-severe allergic reaction, those can receive a direct oral challenge. And patients with a recent history of a severe allergic reaction, such as anaphylaxis within the last 5 years, should likely undergo skin testing first to evaluate their current allergenicity potential. And then lastly, bringing us to the patient education because they're going to be the center of all of this. When we're talking to them about allergies versus adverse drug reactions and their history, the first thing is going to be to differentiate those two and emphasizing that the allergy is caused by the immune system and the adverse drug reaction is simply a consequence or collateral effect of using the medication and how they can differentiate those. Because if they feel nauseous or throw up, that doesn't mean they're having an allergic reaction, since that's something that can be scary to a lot of people. And additionally, we want to coach them or provide a contingency plan on how they can manage a potential adverse drug reaction. So for many medications, if you take it with food, there's less nausea and vomiting. If after taking an antibiotic, there's 1 or 2 episodes of loose stool, you could consider using an over-the-counter anti-motility agent such as loperamide or Imodium. If there's profuse diarrhea, then the patient would need to be evaluated for a Clostridioides difficile infection. But if it's just 1 or 2, that could simply be symptomatic management. And it would need to be a conversation between the patient, provider, and pharmacist. But sometimes we can prescribe medications in a different way that would allow for lower rates of adverse drug reactions. The example that I'm thinking of here would be amoxicillin is 875 milligrams twice daily versus 500 milligrams 3 times daily. We're giving that lower dose can allow for less side effects and adverse drug reactions while maintaining the pharmacokinetic parameter that amoxicillin needs, but this is not going to be applicable to all medications or all sites of infection. So this isn't something to recommend across the board, but could be something to be considered within that patient-provider-pharmacist discussion. And then lastly, if you're able to remove the allergy from your clinic or your facility, that's great, but that allergy is going to exist in other records. And if you say, oh, this patient isn't allergic to penicillin, so I'm going to prescribe amoxicillin, and you send it to the pharmacy, but the pharmacy has the penicillin allergy on record, that's going to alert them and perhaps result in an additional call or confusion and clarification. So it's important to emphasize to the patient that they need to update all their records at all the facilities they're seen at, all the clinics, the pharmacy, the dental office, anywhere where they've told them that they're allergic to this medication. And certain programs have used essentially a business card reminder stating, I'm no longer allergic to penicillins, especially if the patient has undergone a direct oral challenge. And that serves as a visual cue in their wallet when they're at these places, perhaps with their insurance card, to say, oh, by the way, I need to update my allergies and reflect that I'm not allergic to penicillin. So that could be another tool that's used to help encourage patients to follow through on this step, since it can be a while before they're seen at all of these places. So this brings us to our next application. I have a couple patient cases for you all. So for this first one, LD is a 44-year-old male patient who presents to our facility for a sore throat and fever. Following the physical exam, a streptococcal rapid antigen test returns positive and a diagnosis of strep pyogenes, also known as group A strep pharyngitis, this is known as strep throat, is confirmed. The recommended treatment for this condition is oral penicillin or amoxicillin, but you notice a penicillin allergy documented in LD's chart. How do you proceed? Should we give him clindamycin? Should we prescribe penicillin anyway, since most allergies aren't true and current? Should we ask him for more details about his allergy, or defer to someone else and not make the decision ourselves? I'll give you guys a few moments to answer this question. Okay, great. Everyone got the point of this talk today. We want to ask for more details and figure out what happened. So we ask him, and he says he took amoxicillin as a child and he vomited once and has avoided all penicillin-like antibiotics ever since. So how should we respond? Should we say, oh yeah, that sounds horrible. We should continue to avoid penicillin antibiotics. Should we educate him that providing antibiotics can cause an upset stomach, but that's not a true allergy? Perhaps taking them with food can help prevent this? Should we bring up that having a childhood reaction increases the risk of anaphylaxis now? Or state that all antibiotics are equally safe and effective, so there's no downside to avoiding penicillins? Seeing some responses come through. Thank you all for your participation. Okay, great. So everyone got it correct that this is not a true allergy. Once again, I'm going to tell myself that I taught you this as encouragement for the office hours today. And so we shouldn't avoid penicillin antibiotics because this was an adverse reaction rather than a true allergy. And having a childhood reaction doesn't increase the risk of anaphylaxis now, particularly because this wasn't an allergy at all. But if it was that type 1 IgE mediated reaction, we would expect him to be at lower risk of having a true allergy or anaphylaxis now. And we know that not all antibiotics are equally safe and effective, and there are several downsides to avoiding penicillins, right? The broader spectrum antibiotic use, the increased length of stay, the increased rates of multi-drug resistant organisms, the adverse effects, the cost. There's a lot of reasons why we shouldn't avoid them if we don't need to. So I have another patient case, and this is the last one. We have JN, who's a 53-year-old female patient who presents to your facility because she's concerned for a skin infection following a likely bug bite. The provider is also concerned for a mild non-purulent cellulitis, which means there's no pus, but it is a skin infection, and this is typically treated with penicillin. However, JN has a penicillin allergy in her chart with a reported reaction of rash as a child. How should we proceed? Should we give her penicillin since the allergy was a long time ago, so it's probably safe? Should we give clindamycin just in case since a rash sounds like a true allergy? Should we clarify her allergy history further or defer to someone else and not make the decisions ourselves? Okay, great. So the majority of people said to clarify JN's allergy history further. I agree, let's get some more details. We did have a response for proceed with penicillin, and I would say in the larger realm of pharmacists and physicians, you would not be alone in that answer. It's just in our group. But I'm always a fan of finding out more information and then determining if it's truly low risk or not before making that determination. But that might also be my nature as a pharmacist. So when we ask her, she says it was a non-itchy rash as a child when she took penicillin, but she had amoxicillin last year for pneumonia and had no reaction at all. So now what should we do? Should we continue to avoid penicillin in case she's still allergic? Consider further testing to evaluate the allergy? Both of those? Or go ahead and give penicillin for this infection since she tolerated amoxicillin last year? Okay, great. Thank you all for your participation here. And I'm seeing that the majority of people said D to proceed with penicillin due to her recent tolerance of amoxicillin. There, it should be showing for you guys now. And I agree with that because tolerating amoxicillin is essentially delabeling that penicillin allergy. So if we did further testing to evaluate it, that step would be to give her amoxicillin and see how she does. And that happened last year, and she did just fine, which is why we're able to proceed with option D in this case. The last aspect that I wanted to go over is potential barriers to delabeling allergies, because all of this sounds great, but realistically, there are reasons why this isn't implemented across the board yet, even though I think it should be and we should be moving in that direction. And I think that that's what we are doing as a larger society. So, those barriers, first and foremost, include time. Something as simple as a conversation does take minutes out of the day for a very busy and thinly stretched healthcare team, right? So, clarifying each allergy, depending on the level of detail and how many allergies, can take up to 5 to 15 minutes to perform a really thorough interview. And it may be perceived that that time is a barrier to the day to day activities. However, with all of those negative adverse effects and outcomes that have been associated with patients having a penicillin allergy, I think that the time spent conducting a thorough interview is really worthwhile to the patient and facilities outcomes ultimately. So I would advocate that even though I know time is a concern, that this is an initiative that's really worth the time. The next would be clinical expertise. People may not feel comfortable having these conversations of if it was truly an allergy or not, or providing education. Some solutions here are to attend a talk like this one, or there's some other resources available online. Another strategy at the facility level would be to have a formal policy procedure in place that all staff follow so that people know that what they're saying and what they're recommending is consistent across the board and provide reassurance to your staff in that way. The next one is fear, particularly on the patient side of having an allergic reaction, especially as the media or movies may show that every allergic reaction is going to be anaphylaxis, right? And if they know someone who had that reaction, that could be a very real concern that needs to be alleviated and discussed with them. And in certain scenarios, if that's going to be a barrier to delabeling, we could consider a direct oral challenge in order to provide the patient reassurance that they can tolerate this medication and it is safe. And especially if that oral challenge is occurring in a healthcare setting, that can also increase the comfort level for the patient. And then, as I mentioned before, one of the other barriers can be the other records. If that allergy label still remains at the pharmacy or at the hospital or at the clinic, then patients may still not be receiving optimal therapy until we have a standardized medical record across the US, which I don't see coming any point in the near future. As nice as it would be to have all of those up-to-date records, at this point in time, that is a barrier to be aware of. And make sure that that allergy label doesn't get re-added. So the take-home points for today are that patients labeled as penicillin allergic are at risk for many negative outcomes, from receiving broader spectrum antibiotics that are more toxic and less efficacious, to increased rates of multi-drug resistant organisms and costs. And about 90% of patients who are reported as penicillin allergic are not truly and currently allergic. And we can take a simple and accessible step by administering thorough allergy histories to identify patients who are not truly allergic and give them the optimal medication and avoid those negative outcomes. But ensuring staff and patient comfort with removing that allergy label is really going to be key. And we talked about some potential steps to encourage staff and patient comfort. There are a few additional resources that I wanted to share with you all, and these will be posted on our website as well. So the CDC has some resources. They have a whole website regarding penicillin allergies, as well as a fact sheet that can be printed out or potentially posted if it would be helpful, and a blog regarding stewardship in the setting of an allergy, because we have to advocate for stewardship as the stewardship office hours. And Quad AI has quite a few YouTube videos. I've linked one here on how to identify a low-risk penicillin allergy. Shay also came out with a penicillin allergy management course in December that was pretty good. I went through it shortly after it came out, so it's something that I would recommend if you want to learn more about it. And ADHS has quite a few infectious diseases clinicians. Toe and I are two of them, and we have two physicians as well, Neil Ample and Joel Tarikas, and all of us would love to do anything we can to help patients receive optimal therapy and stewardship-minded practices. So please don't hesitate to reach out to us if you would like our input on implementing one of these programs in your setting. I want to thank you for your time and attention today, and I would be happy to answer any questions, but really I would love to hear from anyone on the call, their experiences with implementing this or potential barriers, any stories. We still have, 10, 15 minutes left, so we've got time to chat because this is the open discussion was the point of this. So I'd love to hear from everyone.